Good afternoon, everyone. My name is Trish Tafazio, and I'm the Senior Director of Operations with the Bruyère Research Institute. Thank you so much for joining us today. We apologize that we're starting just a little bit late. We've had a few technical difficulties, but we've got those sorted out now. Thank you for joining us. This is our Bruyère Talks Research webinar series, and it is quite a new series to us. This is the second webinar in our series, and we are planning to have a few additional webinars. So please watch out for those in the future. I just wanted to introduce myself and say thank you for joining today, and I'm going to pass it over to Vivian Welch, who will be your moderator, to introduce the session. Vivian?
Great, thank you, Trish. Welcome everyone to this Bruyère Talks Research. It's my pleasure to introduce Dr. Kevin Pottie and Dr. Gabriel Fabreau, who will be speaking about the equity causes and impacts of the Cargill COVID-19 outbreak among newcomers in Canada. Dr. Kevin Pottie is a professor of family medicine and epidemiology and community medicine. He's also a scientist at both Bruyère Research Institute and the Institut de Savoir at Montfort. And I have to say that from the last 10 years of working with Kevin, his passion for improving health of the most vulnerable is only matched by his creativity. I still remember how he can juggle raw eggs while giving a plenary opening speech, just to show how we really need multiple perspectives to address equity issues. Dr. Fabreau is going to start this off. He's a professor and new investigator in the Departments of Medicine and Community Health Sciences at the University of Calgary. His clinical practice is as a general internist, focusing on caring for socially vulnerable populations at the Mosaic Refugee Health Clinic. And he's going to start us off with an overview of this research and the transmission dynamics. So over to you, Dr. Fabreau.
Great. Thank you, Connie, for the invitation and a chance to present essentially a study proposal that Kevin and I led to study, one of the largest outbreaks of COVID-19 in Canada and we think maybe North America. So I'll just move on. Next slide. I have no disclosures, I guess I should start by saying, I'll try to be fast. Essentially, we recently were fortunate enough to win a CHR grant from the Rapid COVID-19 Operating Grants, and so that was 2 weeks ago. And so I'm just going to present the grant overview and the plan that we have put together. This is the background. I'll just walk you through essentially the grant in short order, and then given it's a research institute, we always appreciate any and all feedback to consider as we continue with this research. So next slide. So Cargill is a privately held international corporation that is one of the largest beef processing facilities in Canada. They have a second facility in Ontario. The one that is where the outbreak in question occurred was in High River, which is just outside of Calgary, just south of Calgary. It's very large. It's been there for about 20 years, and over the time, the production of the facility has increased. On its own, just to give you an idea of how big the facility is, they process, and this is off of the Cargill website themselves on their main page. They process about 4,500 head of cattle daily. They run 24 hours a day, and all by itself, it produces about 40% of the entire beef supply for the country. There's a second large facility called JBS, which is outside of Brooks, also had a COVID-19 outbreak in and around the same time. And the combination of those two processing plants together, it's estimated it covers about 70 to 75% of the entire beef supply for Canada. So very, very large facility. I will also preface everything that I say in this talk with, the research has not occurred yet. So all the information that I'm going to present as background. This is all publicly available information. There's been a lot of interest from the public, and there's been two very thorough investigative reports done in the media, one by the Globe and Mail. CBC has multiple reports, as well as Maclean's magazine. And then the government of Alberta has published a lot in Alberta Health Services, and the government of Alberta have published a lot of information about COVID-19 and related to these outbreaks. So all the information that we're presenting is all publicly available. Next slide, please. Oh, sorry, and I forgot to mention that, again, while we haven't done the research, but the reports are anecdotally from dispatches from clinicians in the field, as well as from these public reports, that the majority of the workers, the employees of the Cargill facility, as well as other meat processing plants, are they come from newcomer communities. And so newcomers, you know, are loosely defined as recently arrived refugees and asylum claimants, temporary foreign workers, which have been receiving quite a bit of press in Canada over the last week, as well as landed immigrants who've become naturalized as citizens in some cases. Next slide. So the background is we think the indexed case, at least this is, has been reported around early April, so April 3rd or so. Within a month, it went from a single index case to this single outbreak cluster. We think includes about 1,600 people by the first week of May. The cluster includes employees of the Cargill facility, contractors and their families, as well as close contacts, and we suspect that perhaps some community spread. As I mentioned before, we think it's the single largest COVID-19 outbreak in a cluster in North America. Certainly it is in Canada. 2 weeks after the initial index case, there was about 350 cases, despite early involvement of public health from Alberta Health Services, which is our provincial health system. But the cases were, the plant was still open and the cases continued to grow. The public health noticed, rightfully so, that they were facing exponential growth, and thus rapidly put together what is called the Cargill Outbreak Task Force, Response Task Force. It then just became the Meat Processing Plant Task Force, because we had smaller, well, some large and then some multiple other smaller outbreaks at other processing facilities, not just in beef. It was a multi-stakeholder response, and their job clearly was to contain the outbreak and to support those affected. The interesting thing about this task force is that it was quite novel for our health system, is that that it included, in a non-traditional way, a very integrated response from the health system, from both acute care and public health, also our primary care networks, rural primary care networks, and as well as the Mosaic Primary Care Network, which I work with closely at our refugee clinic in Calgary. And then because we're very well established relationships between our newcomer communities and our primary care providers at the refugee clinic, and we have long established ties with some of our public health colleagues as well, that work together through the Syrian refugee surge, as well as the Yazidi refugee influx that we dealt with. This broad-based community approach was taken to activate the newcomer communities that were integrated with primary care and the acute care service, as well as public health, and they worked very quickly to try to contain the outbreak. Next slide, please. So, newcomers in COVID-19, I think if there's one thing that we've learned over this pandemic, is that COVID-19 has the ability to shine the light on the systemic and structural inequities that exist in our society that we often see in health and healthcare. We see the fallout in health, and that's how Kevin and I got together to try to pursue this. I was initially working on the acute care side during the pandemic in operations, and then was called in to the Provincial Scientific Advisory Committee when Cargill outbreak occurred, because I have an academic and clinical interest in working with refugees and newcomer communities. So We know that newcomers face many barriers that can increase their likelihood of acquiring infection with COVID-19, but also many barriers that affect their ability to respond to the public health measures and or receive the access to care necessary. And these include things like language barriers, poverty, fear of deportation, poor health literacy, housing conditions, structural racism, and unsafe occupational exposures. Not specific to Cargill, but we know that there's a huge body of literature that supports a lot of these barriers and their associations with health. We're particularly worried about temporary foreign workers. Again, if you watch the CBC National or some of the national news, this has been in the press of late. We suspect that they are at increased vulnerability because of fear of their immigration status being dependent on their employment, and also reluctance to access health and social services due to potentially due to trust. And then as a part of those inequities, of course, the social determinants of health that I've already mentioned certainly can compound COVID-19 infections and then impact the outcomes. And this has been seen across Canada and globally, essentially, across many communities. One thing that is unique to an employment situation is this concept of presenteeism, which I have learned about recently. And this is common among workplaces where disempowered communities may have fear of retribution for missing work, or they may be more susceptible to employer incentives or other mechanisms by which they present to work despite being sick and despite being fully conscious of self-isolation, quarantine, or public health measures. Next slide, please. So the research objectives of our grant, they're quite simple. One, how it spread. It's a traditional epidemiologic infectious disease epidemiology assessment, quite descriptive to try to understand the distribution, the chronology, the direction, reach, as well as the case outcomes of those that were affected. Number two is to understand why it spread. So to explore the determinants, both quantitatively, but also look at social, cultural, occupational, and biological factors. And then third is to understand the perception from those affected of why it was spread. And that's, among all stakeholders involved. And then finally is what was the response, the collective response that I had mentioned, but also essentially to understand what worked, what didn't work, and what couldn't be helped. And then, Kevin and I are particularly interested in how the response was perceived by those affected. We learned many lessons. If I'm allowed just a short detour, as part of the public health training and some of the research I do, I've done coursework that reviewed the Ebola outbreak in West Africa in 2014. And one of the most striking learnings from that outbreak was if you lose the trust of the community members, that it is nearly impossible to control an epidemic. And so in Sierra Leone and Congo, for example, there's many examples that have been written and published about community members having lost the trust or being mistrustful of community health workers or health systems that were trying to essentially trying to contain an Ebola outbreak that was out of control, and it led to disastrous consequences. Patients or folks in the communities obfuscating or hiding symptoms, hiding patients that they knew that were sick, and in some cases, even attacking health workers. So we're very interested in understanding from the point of view of the people involved in this outbreak is what are their perceptions of trust and in institutions such as public health or primary care, their employers, etc. Next slide, please. So I'll speed along this, but the study team is large, is the largest I've ever been on in a very rapid amount of time. We're fortunate that the Chief Medical Officer of Health of Alberta, Dr. Dina Hinshaw, is our principal knowledge user. Also, we're integrated with the public health knowledge users across Alberta, so both locally and then at the zone level. We have a very broad and multidisciplinary study team that includes clinicians, public health officials, researchers from health services, epidemiology, occupational health, infectious disease, public health, sociologists, community engagement, health policy, governance, and as well as legal scholars. And then we have, again, we were fortunate to be able to garner a lot of support in a very short period of time, which I think speaks to the interest that people have in trying to understand the outbreak, which includes branches of the Ministry of Immigration and Refugees, collaborators that we formed over time in the refugee health research world, but also Alberta Health Services strategic clinical networks, which are in and of themselves a novelty, but have quite a bit of scientific firepower. Next slide, please. So the methods, I'll try to go through it so we save time for questions, but the methods are honestly, they're quite simple. It's a case study. It's an embedded case study with a main unit of analysis, which are the Cargill employees and their families, both infected and not. And then subgroup analyses among separate subculture or cultural, self-identified cultural and ethnic groups. We think there's approximately 10 common cultural groups involved. Then the subunits of analysis are the collective responders and other stakeholders, which include public health, the providers, social services and newcomer communities, the union itself, AHS, acute care, and the Cargill management executive, and local businesses in and around High River that were involved. Next slide, please. We're going to use a mixed methods approach. We're going to use a Progress Plus framework to really try to understand the social determinants of health and use the health equity framework across the study. We're taking great care to ensure that we do this in a community participatory way. And so we are recruiting patient partners, not just patient community leaders, essentially embedding them within our research team in a participatory framework as community scholars. They're going to assist with all parts of the research, including cultural brokering, data collection, design, and interpretation. And that's with support from the SPORE platform in Alberta and the patient engagement platform. Next slide, please. Quantitative data sources they're all administrative data sets. So the CDOM data or public health data has a rich data source that includes the case contact and tracing that was done, including symptomatology and laboratory data from the province, healthcare data from NACRS and the DAD to understand those that were either presented to emergency department, urgent care, or were hospitalized. And then social services data were available from our newcomer partners around some of the social needs that were identified by the task force. Qualitative sources plan to do about 20 or 30 employee interviews or family interviews if families prefer to be interviewed together, which sometimes can happen. And then 8 to 10 task force focus groups, and also focus groups across all those categories as mentioned before. And then if we can find some written material, we'll try to collect and utilize that as well if it's available. Next slide. In terms of the analysis, honestly, it is quite simplistic. They're descriptive statistics. We'll do a network analysis with node and parent-child relationships to understand transmission chains that we'll construct, and we'll try to see where it abutted or how it interacted with other community spread or outbreaks within the Calgary zone or geographic area. We're going to describe the health outcomes among those that were affected, and then we'll do some basic regression to look at the factors that were most closely associated with, again, using the Progress Plus framework and other quantitative data to understand what were the factors that were most associated with risk for infection and then poor outcomes. Next slide, please. For qualitative analysis, we'll use a best fit framework. We're going to familiarize ourselves with the data. We'll do indexing. We'll try to use a thematic framework, which is more expeditious than a traditional thematic analysis. We're going to chart and map, interpret. We'll be doing it from our qualitative experts will be leading, of which I'm not one, which may be clear by the way I described this. And again, we'll be including our community scholars. Next slide, please. Sex and gender, but will also be, which is important. I'm very happy that CIHR has made this a priority, but not just sex and gender. We're also going to look at sexual minority status and, again, all of the other intersections of minority status, ethnicity and language, etc. And we're going to summarize the qualitative findings and then integrate those with quantitative to look at both biological variable of sex, but also gender as self-identified, the social cultural aspects. So one brief example is we know that COVID quantitatively globally that the men have worse outcomes than women, at least has been reported up until mid-May in terms of hospitalization outcomes. Why that is I think currently unknown. That's probably a biological factor, but we do know that especially among the workplace that there are, you know, very strong gender factors that permeate employment risk, where people work in a Cargill facility or in a meat processing plant, who's at home taking care of children, who's working in the long-term care facilities, et cetera. And those are all gender aspects of gender, which is sociocultural. Next slide, please. Oh, I apologize. So this is a knowledge translation plan. I will say that it is ambitious. The part of why the team is large is that we really want to produce information as quickly as possible that can be used for this pandemic. Normally, a study of this size, we'd probably want to take 2 to 3 years before we, you know, completely package up and integrate and triangulate our results. We're working on a very accelerated timeline. So, you know, this talk is early knowledge translation, but you know, we're gonna have a multi-pronged approach, which includes having a dedicated study website, newsletters that are regular monthly meetings for our study team, the stakeholders, and then as soon as and as early as data are available, we'll be ensuring that we continuously try to produce data and feed it to stakeholders, and then rapidly, you know, both traditionally through scientific conferences, but also in non-traditional ways through online and newsletters and other ways. In the end, we at a year, we hope to be able to have data both on the quantitative and qualitative side that are integrated, and then be able to formulate a set of recommendations and policy briefs for health system and decision makers to, you know, the goal is to prevent further outbreaks like this in the future. Next slide, please. Study timeline, I'll skip it, but essentially all of those things I said, we hope to have done within a year's time, and which again is very, very tight in the research world. Next slide, please. Yeah, I'd like to acknowledge again, so here are the names of our very large study team, and then our partners and collaborators, of which all have contributed, and we benefit from all the support we've had thus far. And then I'm done.
Great, thanks, Dr. Fabreau. I think we're going to take a pause for any comments in the chat box. So I don't know if Caitlin, if you already have some questions, if there are any questions coming in.
No questions at this time.
So I think it's impressive work, Dr. Fabreau, with such an accelerated timeline that you've got this together, and it's a great example of looking at equity issues in this study. So I
just wanted to thank Gabe and Trish, the organizers, and Vivian. This project is really exciting for us. It touches on immigrant populations, which has been something I've been very interested in, and it also touches in a very large way on health equity. And I think we're going to learn a lot about health equity and about transmission as potentially one of the negative outcomes of health inequity. I just want to make sure I declare that I don't have any financial or academic competing interests to this presentation. We reached 100,000 reported COVID cases in Canada just last week or early this week, and 8,349 deaths. So I think this is really important to recognize. And one of the journalists was calling this COVID-19 the ultimate discriminator, and basically stating that it amplifies the healthcare disparities that already exist. And something that is not always in our day-to-day thinking is that the conditions in which we're living could potentially, dramatically affect people's health. And this just reminds us how fragile life and illness can be, maybe during when you're facing certain inequities. It's also interesting, I think, on the positive side, that Cargill has employed so many immigrants and temporary migrant workers during a very important time, a time when more than 2.5 times the number of people with low income have lost their jobs. And this is also causing a lot of hardship amongst low income and immigrant populations. So I think on the positive side, I think we can say that it's important that our jobs are available. And I think this is what we're going to be wrestling with, is the benefits of Cargill of providing the meat, 40% of the meat for Canada, and providing other services, jobs, but at the same time, how do you operate in a situation where you're able to ensure health and in a reasonable way in your working environment. The other thing that's just a reminder is that 50%, more than 50% of all of our COVID cases have involved people less than 60 years of age. And I highlight this because a lot of those people are in the working age that people were working at COVID. And so sometimes, of course, we have a very unfortunate and horrible mortality rate amongst the elderly. We also still have very high rate of COVID amongst the working class group. In the U.S., they were measuring age and race from the beginning, and the CDC has some really interesting findings that I think came out last week that suggest how basically the death rates for a 45-year-old are 6 times higher for Blacks and Latinos than for white people. This is, I think, very dramatic. I think the other thing that's quite interesting is where they were able to do some modeling and look at the data, and they realized that people determined to be Black have a death rate similar to the white population that's 10 years older than them. So it's like they've lost 10 years of life expectancy. Yes, we have other studies that have already shown this, but I think this becomes incredibly obvious during this pandemic, how much inequity can affect our lives. I think my next slide, well, it just focuses on how much race matters. And until last week in Ontario, we actually haven't been measuring ethnicity and a number of other factors that we need to study equity. And this has been really a horrible thing. For instance, basically there is no data on the race and ethnicity of any of the 1,500 people involved in the outbreak at Cargill. So this is kind of incredible when you think about it. So they were not keeping data. Now that's going to be our job, I guess, is to go and find as many people as we can and understand who these people are and why they faced Cargill. We have colleagues led by, I think, Lawrence Kermeyer and Cecile Rousseau in Montreal, and who've been really working hard and across the country to get these features back into the reporting, and with some support from the Public Health Agency of Canada and the Canadian government. And now finally, Ontario government has brought this back into the statistics, because without the statistics, you cannot solve a problem that you cannot see. it can, and sometimes for me during the epidemic, it really just didn't seem clear who was getting COVID, who was dying of COVID, why, and we didn't have some of the data at the very beginning. And I think now that especially the CDC has it and the UK also has it, it's unfortunate that that ethno-racial minorities are facing higher transmission and higher death rates. So temporary migrant worker programs are quite important for Canada. They've been going on for about 50 years, and they fill the spots in labor that we do not have citizens that can do those jobs, and we need to keep the country working. This is a very historic thing. We actually have 10,000 less births in the past 3 months than would have been expected in a non-COVID period, and we have 360,000 immigrants on hold to come to Canada, and this is when they come in, like, you know, April, May, June. So this is usually a high movement of people. So this is quite an incredible effect on our country, on our economy. And I think it's just important to recognize what a big role they play. And we're hearing about the agricultural workers, unfortunately, who are facing hundreds of COVID positive tests right now. Of course, the food and meat processing that we're talking about. I think long-term care facilities, really, they've played a major role in helping look after elderly people, but they've paid a price for this. And there's many other industries, including fishing, and where a lot of Canada is being kept moving because of this foreign workers program. But the question is, how do we make this program safe, and how do we avoid tragedy? You know, when people are trying, you know, potentially helping the rest of Canada. And I think for me, it resonates. If anyone's worked abroad in you know, developing countries, it resonates how we're seeing often the interface between people coming from a developing country to a developed country. And I would say that we have not necessarily resolved a lot of the safety issues or the equity issues that need to be resolved. It turns into a very big ethical situation. And I think this is what's going to be debated, is to how should people be treated when they're in Canada working. And I think we not just Canada, but other countries are going to have to grapple this. And this is, to me, a global health issue as well. And of course, many people will be doing essential jobs, and so they have to be working. And so, I mean, we had an incredible contribution from immigrant and transit migrant workers. And I think that, you know, this is something that's important to recognize. It's easy to sometimes just to, I think it hasn't been enough recognition of them. It's starting a little bit, but I really feel that they've played a big role. And hopefully, in case, I don't know, other people maybe don't share the same view, but immigration has been driving our population of Canada and the economy of Canada for many years. And I believe that we're going to need to continue to treat people fairly and continue to have immigration, you know, driving our economy. I think that just a quick, I found something, I think CBC talked about what's happening in a meat processing plant. So, you know, it's a little bit of a harsh environment where you have a kill floor, which is where people, the cattle is actually bled, skinned, and hung in a hook. And this is a very moist and, you know, a very, very difficult environment to work in. And this is happening with hundreds of cattle a day. And then you have a fabrication line. This is where workers are traditionally have been elbow to elbow, cutting meat in different sections, and you know, trimming carcasses and removing fat. And again, there's been some changes in the factories to try to prevent infection. But again, we have to kind of watch very closely to see if this environment will still create COVID infections. I think there's also a thing that's been brought up is the speed at which people are expected to work. And I think that's another issue. It leads to, also has led to many injuries over the years, and may also lead to this you know, loss of protective equipment or prevention from COVID. I think that, Gabe kind of went through really the good list of potential social factors that we're going to be studying to understand what really is going on here. And I still feel very happy to be involved because I believe a number of the people with COVID found their way to the Mosaic Clinic in Calgary, and where they felt safe, and that was what kind of triggered the public health investigation as well as other healthcare investigations. So I'd like to think our network of practitioners played a big role in being, on call and ready to do something for people when they were in need, which is what happened during this 3-week outbreak. I think, let's see, I'm going to skip this one. I think we talked about it enough. The languages are a little bit interesting. So far, we've identified 10 languages we're going to have to tackle as we go into the field and use community scholars and probably international medical grads to kind of network and talk, but probably not necessarily face-to-face, but at least through some type of means. We're going to try to be handling the Spanish groups and the Tagalog, Filipino groups, Tigrinya, Ethiopians, Hindu, Amharic, Vietnamese, Pakistani, Arab groups, Cantonese, and Mandarin. So I think that this is I think a bit of a challenge. What I think we're looking forward to, and we're building a bit of a pod in Ottawa to work with a group in Calgary, so that we can actually we'll be part of doing the video interviews as well as Calgary. And we already have several of these language capacities within our staff. So we're very much looking forward to speaking to people. When we I think Vivian made me aware of this BMJ publication by Margaret Whitehead, which talks about a theory of and measurement of socioeconomic status, health inequities at different levels of policy. And I think something like this may fall into where we're going as we try to understand what happened, and then we want to talk about strengthening the individual. What is going to be needed? Is it going to be wage supports or some type of other income supports? We're going to have to strengthen the actual communities that are supporting the workers, maybe. So these communities were, in this case, also vulnerable and had over 500 COVID cases themselves. So we need to protect and strengthen the actual communities of the workers, which I think is a really important way to think of it. And then we have to improve working conditions, which we've been talking about. This one is really important. And then there's potentially more macro policies and programs that we want to address how society is handling its vulnerable workers and how we're actually integrating them into society, which is, I think, again, something that is going to be really important for ongoing health. A lot of people with transient migrant workers, in my experience, they get a health card from the province where they go to work, but I've seen very few in my 20 years, because almost all of them are afraid to use that health card because they think that they may not get invited back next season to work. So there's a situation where they don't feel necessarily that they're going to be looked after. Rather, they kind of keep the health card in the pocket and just try to do the job. I think that's it for me. I can take any questions if people have any.
Great, thank you, Kevin. There is one question already, so yeah, thank you for champing on without your slides. I know we missed out by not getting to see them.
So COVID restrains everything, and in this case, it restrained the data I could use to send my slides. So I guess that's what the message for me about COVID is sometimes. I should have been more modest with my number of pictures. It's okay. Next time.
Next time. So there is one question already, which is whether Kevin, you could provide a list of the languages.
Yeah. So, I mean, I have the slide in front of me, but of course you don't have that. So I don't know how you're wanting that list, whether if you want us to just to send it to you, or do you want me to rhyme them off again?
I think, Caitlin, are we able to send the share the slides somehow after this with panelists, or how would you? I think maybe because it's a long list, that might be more efficient. Is that right, Kevin?
10. Tagalog, yeah. Spanish, Oromo, Tigrinya, Amharic, Hindi, Punjabi, Urdu, Vietnamese, Chinese Mandarin, Chinese Cantonese, Arabic. That's it.
I think someone's showing off. That must be Gabe. But there's actually 11. So I didn't. 10 didn't look as good. So I put 2 in the same category, which is not really proper scientific practice. But I think that sharing the slides, I'd be happy to do that, because I did a lot of work preparing them, and if people might find them useful to look at. But
great.
We can make sure we get to it.
So I think if people would like more information on the slides, they could email brierb@bruyere.org, and Caitlin could share those with you. There's another question about what role does housing play in this spread? So what are owners and management going to do to deal with overcrowding? And that may also be a question for Dr. Fabreau as well. Yeah, maybe if you want to start, Kevin.
I mean, certainly that fits into our kind of our equity analysis progress factors. And we recognize that housing, and it could be income, and there'll be language and transportation. These factors will be really important. That I guess that's our job, is we really believe we need to interview, and we need to survey people and make some decisions as in terms of the priorities and what can be done. I still don't see it as, like I said, this has been a bit of a challenge for a number of years in terms of how best Canada and corporations should treat, say, new immigrants or transient workers. And sometimes there's always this kind of a bit of a culture shift in what people are willing to accept in terms of living, because of where they're coming from may be different. And so I guess I think that, but if it's important for health, then I guess there's going to have to be some type of program. And certainly Immigration Canada has developed many programs to improve the integration of people in Canada. I'd say that they haven't developed maybe as many for the transient migrant workers. And so maybe that's what we're going to see, is that there could be a little bit more improvement toward us, helping people settle in a reasonable housing situation. Gabe?
Gabe, did you want to comment?
I think, yeah, I echo everything that Kevin said. We know that housing is probably the most important determinant of health among the social determinants of health. And there's lots of data to support that. I guess in the short term, with respect to COVID, dispatches from the field, and operationally, an isolation hotel was set up as a part of the response to these, to help those that couldn't isolate at home, for those that were unable to due to space limitations. So that directly would be a result of overcrowding. We don't know yet. The answer is we really want to find out, and this is why we have to do the slow, the transmission chains and the epidemiology, and then look at the factors associated. Certainly we think housing is an issue, but I think we have to do the research to know what was the direction of spread and where was it. So we also know that people that don't have good housing can't isolate and can't quarantine and can't, even if they have high health literacy and want to be as judicious about taking advice from health. And again, dispatches from colleagues in the field and from the rural PCN in High River is that the people involved in this were absolutely participated as much as they could to try to reduce spread, and sometimes there are structural limitations which prevented them from doing so. So that's, our goal is to try to understand these things.
Great.
And I don't think it's, just to highlight, I really don't, this is not a black and white issue. We have a lot of people are very happy to have a job, and sometimes have had a job even for years. So it's not about necessarily removing people from gainful employment. I think the point here that I'm interested in is it's a little bit about like creating a health equity environment that gives people a fair chance for health, which is what health equity is. So we're hoping that we'll be able to make some significant recommendations that all parties will be happy with, which means the communities of immigrant communities, but also the corporation community. I think that also the practitioners in public health. So I think it's going to be about creating something that people will feel like, yes, there's evidence for this, and we really want to move and make these changes.
Great. I see that there are no further questions at this time, and we're 2 minutes to time, so we probably should wrap up. So I just want to thank you both for really presenting this. I think it raises an interesting question about how this kind of investigation of a particular outbreak and the transmission dynamics, how it'll apply to other types of outbreaks, and really bringing this equity lens to all outbreak investigations related to COVID-19. So just want to congratulate you, and to all the audience, this is part of a series, so we really encourage you to look at the Bruyère series coming up, and please get in touch if you would like the slides at the BRIIRB@bruyere.org. So thank you both.
Thank you, Vivian.
Yeah, thank you kindly for having us, for hosting us.
Yeah, thank you. All right, have a good afternoon. Thanks.